Good morning. Good morning to all of you, and it's my pleasure to be here in front of all of you. And I thank the organizers for giving me the opportunity. And the business given for me today is to deal with the fungal infections as well as the viral pneumonias. And I'll be delivering my lecture back to back. And it's pleasure to be amongst you. It's nice talking to the president of SPOI, and I heard that he's basically from Tamil Nadu, and that too from Tanjore. Nice, sir. And any student always thanks their teachers, and unfortunately this great gentleman is not here today. Professor Randeep Gulere is my mentor in pulmonology, the director of All India Institute of Medical Sciences, also the personal physician to the Prime Minister of this country, the great man who inculcated all the pulmonology things to us. And my next teacher, Dr. Professor J.C. Kilnani, the doyen in critical care and non-invasive ventilation, and my mentors in the pulmonology field. We are going to have the National Guidelines meeting bronchoscopy tomorrow at Delhi, and thanks to them for their efforts to shaping us. So invasive fungal infection is associated with high mortality, and there should be high degree of suspicion required for the early diagnosis, which is crucial for successful outcome. Day in and day out, we see a lot of fungal infections, and in November and December, especially the place from where I come, Coimbatore, we see a lot of viral diseases, which we'll be dealing with shortly. And we have close to 110, 120 immunosuppressed patients post chemotherapy, so we see a lot of invasive fungal infections, so it's quite common. And multiple risk factors and overall increase in the population of immunocompromised hosts contributes to the increasing prevalence of invasive fungal infections. And confirming the diagnosis of invasive fungal infection in immunocompromised patients remains one of the greatest challenge to all of us. And these are the risk factors of invasive fungal infection. You know, the adult patients, the solid organ transplant recipients, and patients with malignancy. I'm sure that each one of you will be seeing one among these patients daily. And you can list any number of risk factors that it predisposes to the invasive fungal infections. So how to classify the pulmonary fungal infections? It can occur because of defects in T cell function. It can occur because of defects in phagocyte function. So by the mechanism itself, we can come to a conclusion that what kind of fungal infection that this patient has. The situation wherein you have T cell dysfunction, you can have histoplasmosis, blastomycosis, coccidiomycosis, paracoccidiomycosis, cryptococcosis. Don't think that it is common only in the West. It is common in our country itself, and we see day in and day out patients like this. And when there is a defect in phagocyte function, you can see all these fungal infections. And these are the systemic fungal infections that are reported from our country: histoplasmosis, blastomycosis, penicilliosis, and sporotrichosis. And these are the opportunity fungal infection. I am sure that all of us will be seeing candidiasis daily, either invasive or non-semi-invasive forms, invasive aspergillosis, cryptococcosis, and zygomycosis, and so on, so forth. We have listened to the great experts talking about HIV sometime before, and PCP comes with that. Sometimes, day before yesterday also, we had a patient with HIV presented with PCP, and later on we diagnosed that HIV is a predisposing factor for that, and other rest of the fungal infections. So these are the diagnostic criteria. And you should have either histopathological evidence of fungal infection, or cytopathological evidence, or direct microscopic examination of culture of the specimen collected from the affected site, and culture positivity in the blood, or you can do some serology to confirm what it is. So you have predisposing factor, host factor, you have clinical criteria to diagnose this. And when you call it as probable invasive fungal infection, when you call it as probable invasive pulmonary fungal infection, you have a predisposed individual for invasive fungal infection, and you have consistent radiology, then you call all this patient as having probable invasive fungal infection if you are not doing biopsy to confirm what it is. So let me start with one of our cases which are shown here are real patients. Some of them are in the process of publication. So this is a 55-year-old male. Is a fireman, chronic smoker, came to us with uncontrolled diabetes mellitus with HbA1c of only 11.2. And he presented to us with cough, mucopurulent sputum of 2 months duration, fever of 2 months duration, and with shortness of breath. and he received multiple courses of antibiotics, and professor from the South Africa was telling to us sometime before that lot of the patients used to get empirical ATD before they reached to them. So likewise, this patient also received empirical ATD based on the symptoms as well as radiology. And I keep remembering my mentor saying that all diseases in pulmonology presents with white shadow in chest X-ray. That does not mean all patient has tuberculosis. Whatever you read in textbook are there in the patients. It is up to us to pick up. So this is an era of evidence-based medicine. So we need to prove what it is before we are treating. And we need to find out what the patient has, rather what we think in a patient. So that holds good for invasive fungal infection upright. So in a patient who has these symptoms with the predisposing factor, if they are not improving with this kind of treatment, means something else. It is not drug resistant tuberculosis. It is not whatever it is, because there is no proof of tuberculosis. So obviously we need to move into other etiologies. So this is the imaging of him. So he is moving around with consultants for months together. This is an X-ray. You can see multiple cavitating lesion in the upper zone, mid zone, as well as in the left mid zone, and patchy consolidation left upper lobe. And this is the corresponding CT. You can see very thick wall, irregular interior wall, and the nodules surrounding. And you can give differential diagnosis. It can be necrotizing pneumonia, fungal pneumonia, mycobacterial infection, malignancy, organized pneumonia, or GPA. But the job of us is to find out what it is. And obviously you will tell it is fungal infection, because that was my topic today in this. So it is also fungal infection. And that turned to be invasive pulmonary aspergillosis. That patient galactomannan was positive, and biopsy showed classical aspergillus infection of these samples, which was taken through transthoracic samples. So antibiotics have gone, anti-tuberculosis drug have gone, the treatment for MDR regimen has gone, XJR regimen have gone. It's a simple voriconazole would have made difference in that patient with the control of diabetes mellitus. So that's it of fungal infection. So that tells us the importance of reaching the diagnosis as early as possible in a given situation, especially if the patient is not improving. So what are the diagnostic problems? What are the diagnostic problems in these patients? The clinical features of fungal infections are very non-specific. Imaging findings can be non-specific, as we have seen earlier. The laboratory diagnosis takes long time for report to come, because till the patient report comes, patient will not be there for you to treat. So it's very important that we take a clinical call as early. And culture positivity will be seen only in less than 50% of biopsy proven cases, and demonstration of fungi at times does not differentiate between colonization or invasive fungal infection. So as a clinician, we need to take a call in a given patient. That holds good especially in Candida infection, because the presence of Candida colonization does not mean that that patient has invasive candidiasis. So you need to take a clinical call in a given situation. And invasive procedures of tissue sampling often is not possible, especially if the patient of you is in critical care in ICU. So this is a real problem. Invasive fungal infection is a real problem. We don't have great data from for us to share, but it is there. It is there, and now the increase in awareness of these infections and increase in the diagnostic modalities available in each part of our country, the number of fungal infections which are picked up are very much more. Immunosuppressed patients are living longer. The large number of the cancers being diagnosed, and people are getting treated. So when you have a large number of armamentarium for treatment of all this, you will have simultaneously other problems rising in. Here it is fungal infection. So you can see from 1979, this graph beautifully tells that it keep rising. And I'll tell you here that this number is very less what it is actually in a clinical practice. The reason why is we don't publish what we see every day. So that's what makes difference here. And these are the common fungus which are reported from the EPICS 2 study at JAMA. So what are the clinical features? When a patient comes with, see, even in a pulmonary fungal infection, patient can come with cough, fever, weight loss, and shortness of breath. You can give these symptoms for any number of pulmonary diseases. So it's up to us to give an importance to this diagnosis in a given predisposed individual. So if a patient with pulmonary symptoms has nasosynal symptoms, probably you have to think of possibility of IFI in that given patient, in a predisposed individual. If you have nasal discharge, epistaxis, and all these symptoms, please be careful that whether the patient whom you are dealing with has IFI or not. These are the clinical features. If you go through this, you can name any number of pulmonary diseases which are listed in any of the textbooks in pulmonology that will have one among these symptoms. So how to diagnose? It is existing. So So we need to go for diagnostic modalities available, either semi-invasive, invasive, or some sort of the serological thing, the test to diagnose. So these are some of the clinical features, non-pulmonary symptoms which suggest. So moving to invasive aspergillosis, this is a spectrum. These patient can have without any sequelae. There can be aspergilloma, especially this happens when the patient has the tuberculous lung cavities and gets colonized with aspergillus, and chronic CCPA, what we call chronic necrotizing aspergillosis, invasive pulmonary aspergillosis, and ABPA. ABPA is quite common. The national data which are published, the incidence of ABPA is around 14% in patients with bronchial asthma seeking a health care at OPD visit. In patients who are admitted in ICU, the incidence is between 30 to 40%. So because of, and in our practice, we always screen for ABPA in any patient who comes with bronchial asthma. So that is a norm now. So if you start looking for it, you will see more. You will see more. And invasive IPA we see because of number of the immunosuppressed patients we are seeing, and CCPA is also common. CCPA, in our understanding, is treated as tuberculosis as relapse every time. Every time it is being treated like that, because the symptoms of CCPA are quite similar to tuberculosis. And these are the classical risk factors of IPA which we have seen. So CT in IPA can detect the problem very early. The halo sign can be one of the suggestive feature of IPA, and early CT and initiation of specific antifungal treatment is very important. And these are some of the imaging findings in IPA. You can see. So this 41-year-old gentleman came to us, a diagnosed case of acute myeloid leukemia, presented with fever, cough of 1 month duration. He was evaluated with respective tests, CD chest, serum galactomannan, and bronchoscopy. This is his X-ray. If you it can be passed as normal, but actually it is not normal, and you have a left lower zone lesion here, and this is the classical CT. The hematological malignancy patient on chemotherapy comes with chest symptoms, and this is the CT. Most likely, with this, seeing this image itself, you can say that it is probable IPA. You can see varying size nodular lesions. Some are cavitating in various stages, and some are located at the peribronchovascular region. So it can be airway invasive aspergillosis or invasive pulmonary aspergillosis. So here, how we can diagnose is, you can do either bronchoscopy, you can send ball for galactomannan and culture, or you can do, this is a subpleural lesion, you can do transthoracic sampling, and you can find out. This patient underwent bronchoscopy because he was not willing for transthoracic sampling, and bronchoscopy showed galactomannan positivity. The ball galactomannan positivity is much sensitive than serum galactomannan. So in patients who undergo bronchoscopy, we always submit the ball sample for galactomannan because sensitivity is very high, especially in immunosuppressed individuals. So this patient was turned to be IPA. Look at this patient. This patient is a CA breast, post-op and post-chemo, presented with cough, fever, and streaky hemoptysis. Based on this X-ray, this patient was given antituberculous therapy without any proof. And in an era of evidence-based medicine, and we need to look into other causes of infiltrates, especially if they are not improving. And when we did a CT, this was his picture. We thought it is metastasis, varying size, nodules, disseminated, bilateral, and more in the lower lobe dominant. So lower lobe dominant lesion, we thought it is hematogenous, but we wanted to sample. When we sample it, it turned to be aspergillus, and it improved with voriconazole. This 20-year-old male, young diabetic, type 1 diabetes, poorly controlled, presented with chest symptoms, sputum ABA was negative, and started on ATT outside. So this is what happens. This is what happens when you don't chase for diagnosis. And later, this patient presented with DKA, and this was the X-ray. This was the X-ray. Bilateral symmetrical lesions. Some are asymmetrical. You can see consolidation middle lobe. Some are cavitating. Diffuse, bilateral, varying stages, and sampling showed. Sampling was suggestive of invasive pulmonary aspergillosis, and he was treated for the same. This 50-year-old female underwent nasal polypectomy in 1983 and had vomiting and headache in 1990, and she was diagnosed as right sphenoid wing meningioma, and she underwent craniotomy, and that sample showed biopsy sample from the biopsy sample showed aspergillus infection. She was treated with amphotericin B. In 2000, again she presented with bilateral maxillary sinusitis, And first showed fungal granulomatous inflammation, and she was treated with amphotericin B. In 2013, she was landed with us, headache and right shoulder pain and transient ischemic attack. And this was the CT. You can see lesions of old lesions. You can see, and this was the time at which she underwent craniotomy, sampling, and this is the time she landed with us. There might middle lobe consolidation. There is collapse. If you look at there is internal lumen irregularity. So that's why she underwent bronchoscopy. Bronchoscopy showed this lesion. When we biopsied this, it was consistent with aspergillosis. So this patient had disseminated aspergillosis, and she was evaluated for immunodeficiency and treated, and she improved. This 42-year-old gentleman, the post-renal transplant on immunosuppressants, came with fever, cough and breathlessness. Serum galactomannan was elevated, and this was the X-ray in November 2012, and this was the January 2013. You can see progressive increase in and dissemination in the size of lesions, bilateral, some are cavitating, beautiful lesions, very characteristic of IPA. And this is another patient who had joint involvement, brain involvement, lung involvement, and turned to be IPA. This patient again had treated for lymphoma, presented with fever, cough and breathlessness. He took ATT, no response, and this is the serial image. You can see serial image. So he need to wait for till 4 to 6 months to diagnose invasive fungal infection. If you don't diagnose invasive fungal infection early, then mortality is very high. So later he was diagnosed as IPA and started on treatment and improved. You can see the serial CT also. Serial CT starting from June 2015 and to September 2015, there is gradual increase in size of lesions, and later he was diagnosed as IPA and received treatment. So whenever a patient is posted for bronchoscopy, we always prefer to do galactomannan in the bronchoscopy sample because sensitivity is very high and evidence suggests the same. And these are the treatment. I am going to deal with treatment because all of you know that how to treat these patients. So it's quite common. It's quite common. So IPA is quite common. Day in and day out we see, and the gradual increase in the number of immunosuppressed patients, the number of aspergillus infection also increasing. Coming to the candidiasis, it's quite common in critically ill patients. It can present with either bloodstream infection or catheter related infections, or they can present with UTI or intra-abdominal infections. Candidemia is associated with when the patient is admitted for prolonged stay in the hospital, especially in ICU, when there is prolonged duration of mechanical ventilation, and you can have candidemia in a predisposed individual. This is the data from AIMS, and these are some of the candida subtypes which are common there. As against the rest of the country, we see lot of tropicalis, candida tropicalis there. And these are the two main forms of predisposing factors for candidiasis. One is colonization, which is a predisposing factor for candida, and another is alteration in natural host barriers. For example, if there is a wound, surgery or insertion of indwelling intravascular or urinary catheters, then risk of candidemia increases. These are the portal of entry, and these are risk factors. So if you look at these risk factors for candidiasis, if any patient is admitted in ICU, have this, will be having one among these risk factors. So if the patient is not improving, the number of hospital stays is increasing, and sepsis is not getting resolved, please think of invasive fungal infection and especially candida in this setup. These are some of the candida score which we used to do, and this scores and candida colonization index are basically came to help the clinician before the culture report comes, so that you can start therapy very early. And these are the manifestations of candida in the lung, and it can present with cutaneous lesions, candida ophthalmitis, and we have seen few cases of hepatic and splenic candidiasis in predisposed individuals. So this is one of our patient, bilateral lung infiltrate, ICU, did not improve. You don't believe that we lost this patient couple of months before, but he was there. He used to develop recurrent infection, recurrent sepsis, recurrent septic shock. He used to go home, and recurrent antibiotic exposure. And finally, we were looking out the cause for this infiltrates, and finally his blood culture grew candida species. So now it is proven invasive candidiasis, and this is the X-ray after giving appropriate treatment for candidemia. We give candida treatment after the last culture negativity for 14 days from that last culture which was taken. So coming to the zygomycetes, is also common because of sudden increase in the number of diabetic patients which we see, and the epidemiology of diabetes, the number of poorly controlled diabetes and number of patients who present to us with DKA, number of zygomycosis also is increasing in number. And these are the predisposing factor. The commonest predisposing factor is diabetes mellitus, steroids, immunosuppressive drugs, and hematological malignancies. And this is how you, the MICAR looks in the histopathology. So it's more common in neutropenic and hematological malignancy patients. One of the common presentation is this, and radiology they can present with either consolidation, nodules, or cavitation, and biopsy is crucial for the diagnosis. If you don't diagnose pulmonary MUCAR very early, the mortality is close to 70%. These are the various clinical features they can have, the various radiological features of pulmonary MUCAR they can have. They can present in either one of this form. So it's up to us to diagnose. So all reverse halo, this is the reverse halo. Previously it was said that presence of reverse halo sign in a CT was highly consistent with invasive pulmonary fungal infection, but it is not so. There are a lot of conditions which can also present with same reverse halo sign, and to name few, this is one of the reverse halo sign which we published in BMJ, classical tuberculosis. This was proven by sputum sampling and gene expert, and this is a reverse halo sign. So presence of reverse halo sign in a predisposed individuals is not the conclusive proof for invasive fungal infection. We need to look into other etiologies. We need to look into other workup for the cause of the radiological abnormality. And this is the another patient who had reverse halo sign in pulmonary embolism. So we thought this is invasive pulmonary fungal infection after seeing this. But if you look at, if you trace the pulmonary artery in the contrast film, you can see the thrombus sitting there. So it is a reverse halo sign secondary to pulmonary embolism. What I am trying to tell here is presence of reverse halo sign, as it was thought previously that it is suggestive of invasive pulmonary fungal infection, it is not so always. It's not so always. This 52-year-old gentleman came to us with poorly controlled diabetes with cough, fever, and hemoptysis of 3 months duration. Chest X-ray showed left midzone cavity, and he developed massive hemoptysis and got intubated. So this is X-ray. This is the X-ray. So first differential, always everybody will keep in mind that it is pulmonary tuberculosis, but here it was negative. And this is the X-ray after he worsened, developed massive hemoptysis and got intubated. So this is CT. CT shows very, very interesting picture, and this is a cavity, a necrotizing cavity on the left side. But if you look at the contrast film, the pulmonary artery going into the cavity got dilated. This is aneurysm. So presence of artery aneurysm in a cavity in lung is more suggestive of either MUCAR or nocardia in our experience. So this is what the CT on the sagittal section, you can see very much dilated pulmonary artery, and this is the reason for hemoptysis in that patient. So what we did in this patient, we did a percutaneous thrombin infiltration into the left pulmonary artery aneurysm, but it did not succeed, and bronchoscopy showed extensive blood clots, and one day he developed massive hemoptysis and patient underwent emergency pneumonotomy and his life was saved. This is the X-ray after left pneumonotomy. You can see the clips there. So biopsy from the sample, pneumonotomy sample was consistent with mucormycosis. This 36-year-old male, diabetic, came with fever, cough and shortness of breath of 1 month duration, and this is the X-ray. You can see left lobe zone consolidation. This is CT, left lobe zone consolidation. And because of internal luminal narrowing in the left lobe bronchus, you can see in the CT, this patient underwent bronchoscopy. And the bronchoscopy showed the intraluminal growth in the left lobe bronchus. Smooth globular growth was seen in the left lobe bronchus, and the biopsy from the same showed endobronchial MUCAR. And this patient, the treatment for MUCAR is always surgical resection. But this patient was not willing for surgical resection, so underwent systemic as well as topical liposomal amphotericin B via bronchoscopy. And after weekly instillation of liposomal amphotericin B 25 mg via endobronchially, the lesion completely improved, and this we published. There are only few data of endobronchial amphotericin B instillation for mucormycosis. This is one of the report which we published sometime before. And you can see after endobronchial instillation of liposomal amphotericin B, a consolidation which was there in the left lower lobe, the endobronchial growth which was visible at that time completely regressed now after treatment. After treatment, this patient, poorly controlled diabetes, was not willing for surgery. Actually, she would have undergone surgery, but he was not willing. And this is a novel therapy which we did, and he improved. And this is another patient who presented with endobronchial mucor, biopsy proven mucor. You can see the growth. So this 56-year-old, very interesting case, diabetic hypertensive, came with left eye swelling and nasal discharge and subcutaneous swelling. And this is the MRI picture. You can see there is the growth, the polypoid lesion. You can see in the posterior aspect of the globe. Interestingly, she had subcutaneous swelling just below the right clavicle. Just below the right clavicle. We did an ultrasound. Ultrasound showed heterogeneous lesion. We did a sampling. Sampling was suggestive of mucor. Mucor. We never have seen mucor in the subcutaneous space. And this is one of the first patients which we saw that apart from these areas, it was also there in the subcutaneous area. So this is the histopathology of this showing mucor. This is the mucor species. So this is another patient who again came with hemoptysis. Right lower lobe. You can see large pseudoaneurysm here. Very large pseudoaneurysm. And this patient was not willing for surgery, which was suggested to him to undergo. And later, via the pulmonary artery, we did endobronchial occlusion of this pulmonary aneurysm neck here. So we deployed a device here, thinking that the blood supply to this sac will cut off and the aneurysm also shrink in size. And this is a deployed device. And after deployment, you can see the complete resolution of aneurysm here. And coming to the cryptococcosis, which can also affect the lung, it can present with either CNS involvement or pulmonary involvement, or it can be disseminated. These are some of the pictures. And this is one of our diabetic patient who came with cough, fever and headache. And if you see here, there are multiple bilateral nodules. Multiple bilateral nodules. We were just wondering the etiology. When she had a headache, we did an MRI. MRI showed multiple dot-like lesion like this in the both basal ganglia. Initially, after looking at this, we thought it is lung cancer. But when he did a biopsy from the mass, it showed features of cryptococcosis. It showed features of cryptococcosis. So because there is a CNS lesion, we did a CSF analysis. CF analysis also tested positive for cryptococci. When we did a serum also tested positive for cryptococcal antigen. Sputum also tested positive for cryptococcal. So this is a disseminated cryptococcosis who improved with treatment with liposome amphotericin B and flucytosine. Later, she was switched over to fluconazole and subsequently improved. Histoplasmosis, also common in our country, especially this is common in North India, Northeast regions, but it's not so common as it is reported from the West, but sporadically we see this infection also. Look at this patient. This patient came with cough, fever. The CT chest showed bilateral miliary lesion, and people thought it is miliary tuberculosis. But in the available abdominal cuts of the CT chest, we saw the adrenal swelling. Initially, we thought malignancy, so we did a biopsy of this adrenal mass. It showed histoplasmosis. And later, after treatment, this patient developed this black lesion. Later, he developed adrenal insufficiency because of histoplasmosis and improved. And this patient presented with hemoptysis. If you look at this CT carefully, you can see the endoluminal growth in the lower trachea. Here, there is a small projection. That is the cause of hemoptysis. When we examined him, his name is Washington, but living in India. So not went to US, but had that name. He was from Assam, and when he examined the skin, this is, I think it is the thigh, proximal thigh, we saw this lesion. And he had another lesion over the scalp. When we did a biopsy of the cutaneous lesion as well as the tracheal lesion which I have showed you came as histoplasmosis, and he improved with the therapy. This is a patient which is a very interesting patient. To best of my research, the search in the literature, I could not find any report on this. This patient I saw on the 15th of this month presented with hemoptysis. And when I did a bronchoscopy, it showed blackish tissue over it. The biopsy sample was consistent with chromoblastomycosis. So the endobronchial presentation of chromoblastomycosis never been reported in the literature. And what I am trying to tell here is, if you look for the alternative etiologies, we can find always. It was thought that invasive pulmonary fungal infection are uncommon, but it is not so. In this patient, there was no diabetes, there was no immunosuppressant intake, there was no history of malignancy, but still the patient had fungal infection. I am not going to talk in detail about PCP because they have already been dealt. It's one of the commonest, see nowadays the PCP is being classified under fungus, and I am not going to talk about this because after this surge of HIV, immunosuppressed individuals, cancers, the PCP incidence has increased like anything, and these are risk factors. I am not going into detail, and like this the patient can present with. They can present with acute respiratory failure in a predisposed individuals. You can see bilateral extensive GGOs. If you sample it, majority of the time you will see PCP, and you treat them, they will improve like anything. This is another of our see breast patient post-op, for the post-follow-up, developed fever, dry cough and respiratory failure, classical bilateral perihilar consolidation, very much consistent with PCP and improved with PCP treatment. And to conclude, trends of fungal infection is increasing in the day-to-day practice. The number of fungal infections, pulmonary fungal infection reported from our country are less because of less reporting, non-availability of the tests to confirm the fungal infection, and the lack of awareness. But nowadays the trend of fungal infection is increasing overall in the globe, and that too in our country. And invasive pulmonary fungal infection patients present with non-specific clinical symptoms and non-specific clinical signs. That is very important. So suspicion is the key for the diagnosis in these patients, and laboratory diagnosis takes time, and indirect methods of diagnosis have revolutionized the treatment of IFI. Early suspicion and early initiation of antifungal treatment at high risk individual is a key to successful outcome of these patients. Thank you.
Alors, est-ce que vous avez des questions sur les champignons, problème que vous rencontrez souvent? Pierre Lair.
Yeah, thank you very much for this good topic. I think histoplasma capsulatum is very frequent in Africa and also in Asia in immunocompromised, in HIV patient. We find several cases in Cambodia in a study on pneumonia in HIV patient. Bile, bronchoalveolar lavage give. So when you have a miliary, doctor give TB treatment. If patient is not improved in few weeks, think fungal disease, and often is histoplasmosis or penicillium also.
Yeah, so I fully agree with you, sir. The thing is, after the surge of the HIV as well as the endemic zones, histoplasmosis also occurs in patients who are non-predisposed. So as far as the invasive pulmonary fungal infections are concerned, it is not that they should occur only in predisposed individuals. Those patients who are immunocompetent like us and like you, these infections are common. The histoplasmosis, the cryptococcus, whichever I focus there, are in immunocompetent individuals. I fully agree with you, the epidemiology of the disease and predisposing individuals.
D'autres questions? Any experience with resistant voriconazole resistant aspergillosis?
No. No, we have not come across, because our teaching here was, or our practice was, not to touch the voriconazole until unless you prove aspergillosis, IPA. So that's it. So in a critically ill patient, even if we suspect IPA based on the radiology, we don't start them on voriconazole. Number one, it should not be started. Number two, it's a very costly drug for us, for the patient to afford, and they need to take it for months and years till the immunosuppressed state goes off. So our practice, our teaching is to use amphotericin B, considering the widest spectrum of action of amphotericin B in a given individual. And once we establish the diagnosis, we switch over from amphotericin B to voriconazole. And after voriconazole, they all improve, and we never had situation wherein we had a voriconazole resistant state. Maybe if anybody could have come across, they can share it. Because voriconazole is such a wonder drug that it melts the disease, provided you use the drug in a correct situation after diagnosis.
Je sais pas si vous avez compris, mais donc je lui posais la question d'est-ce qu'ils ont des expériences de... Est-ce qu'ils ont des expériences d'aspergillose résistante au voriconazole? Il dit non, le voriconazole c'est tellement cher à utiliser pour eux et les patients devront le prendre tellement longtemps qu'ils réservent ce traitement à des infections prouvées. Donc ils donnent de l'amphotericine B de manière générale, mais ils réservent le vorico que aux gens pour qu'ils ont prouvé définitivement une infection. Donc est-ce que vous avez cette même expérience? Est-ce que vous voulez partager ces choses avec lui? C'est ce qu'il demandait à la fin. Est-ce que vous faites comme ça? I agree. D'autres questions? Non?
Shall I continue?
Donc le deuxième topo va parler des pneumopathies.
Question. Juste la durée de traitement pour l'aspergillose. Souvent, quand on termine le traitement de 6 mois, par exemple, chez les asthmatiques qui font l'aspergillose, pour 6 mois et dans le plupart du temps, moi j'ai 2 ou 3 patients qui ont récidivé aussitôt après l'arrêt de traitement. Est-ce que faut-il traiter pour 1 an, 2 ans, 3 ans? Qu'est-ce qu'il faut faire dans ce cas-là? Parce que c'est vrai que récidive aussitôt. Et au moins, il faut récidiver, il faut recommencer la corticothérapie, il faut recommencer tout. Donc c'est un peu très dur comme traitement à infliger aux patients, puis pour nous aussi.
So he asked about the duration of treatment for aspergillosis, especially in asthma. He said that after the 6 initial months of treatment, sometimes he has relapses. So he needs a patient to take the treatment a bit longer for 1 year or 2 years. What's your experience about that, and what's the initial duration of the treatment for aspergillosis, especially in asthma?
Yeah, so I think the question is with reference to ABPA in asthma, because the aspergillosis is a varied spectrum. You can have ABPA, allergic bronchopulmonary aspergillosis, can be invasive pulmonary aspergillosis, it can be CCPA. So we need to find out, I think the question is the treatment of aspergillosis in asthma patient. Am I correct? First is to find out what is the clinical syndrome the patient has, because the treatment is different.
Donc, quelle est la forme clinique? Est-ce que c'est juste une ABPA ou est-ce que c'est autre chose?
If it is going to be invasive pulmonary aspergillosis in asthma, the frontline therapy is voriconazole. If it is going to be allergic bronchopulmonary aspergillosis in asthma, the treatment is steroids.
So, si c'est plutôt une aspergillose invasive, il voudrait préférer le voriconazole. Par contre, si c'est une ABPA, plutôt pas de voriconazole.
The guideline for the treatment of ABPA in asthma, in a first diagnosed fresh case is used to use steroids, 0.5 milligram per kg of prednisolone equivalent. Every 6 weeks you decrease the dose by 5 milligram to the duration of 6 to 9 months.
Donc pour la BPA, la recommandation c'est de commencer par des corticoïdes qu'on diminue régulièrement toutes les 6 semaines pour une durée totale de traitement d'à peu près 6 à 8 mois.
If the patient relapses
en cas de rechute
of ABPA, or if there is any contraindication for the use of steroids, for example diabetes or other contraindications, then the therapy of choice is itraconazole.
Donc si en cas de rechute ou s'il y a une contre-indication aux corticoïdes initialement, là le traitement de choix est plutôt itraconazole.
In a relapse ABPA, we use treatment up to 1 year. Treatment from 9 months to 1 year.
En cas de rechute, il utilise un traitement de 9 à 12 mois dans ce cas-là.
But if it is going to be invasive aspergillosis, then the treatment duration should be somewhere between 4 to 6 months if the patient is immunocompetent. If the patient is immunosuppressed, then the treatment of invasive aspergillosis should be continued as long as the immunosuppressed state continues. So it is very clear about the treatment.
Donc en cas d'aspergillose invasive, la durée minimale pour un patient immunocompétent c'est au moins 4 à 6 mois. Et si le patient est sévèrement immunodéprimé, la durée du traitement doit être aussi longue que la durée de l'immunodépression. Tant que le patient reste immunodéprimé, on continue le traitement antifongique.
Si j'ai bien compris qu'au départ, on n'utilise que la corticothérapie sans itraconazole.
Pour la BPA, c'est ce qui propose.
Est-ce que c'est logique?
Oui, parce que c'est une maladie allergique, c'est pas une maladie au départ fongique, c'est une allergie à Aspergillus.
Oui, mais on augmente la sévérité de la maladie et l'évolution aussi de l'aspergillus.
So he asked the question for ABPA. Is it logical to start only with steroids? For ABPA, is it logical to start the treatment only with steroids? Because it can increase the risk of disseminate the fungi.
The question is why steroids should be given in ABPA? Yeah, that is a very interesting question. ABPA is an allergic manifestation of, it's a hypersensitivity reaction to Aspergillus spores. So any hypersensitivity, the idea is to give steroids. It's a little paradox. It's a little paradox, even though it is a sensitization. It is a fungal sensitization to the Aspergillus spores. Since it is a hypersensitive phenomena, it should be treated with steroids.
Donc c'est ce qu'il dit. Il dit comme c'est un phénomène allergique d'hypersensibilité aux spores d'aspergillus, on doit traiter ça comme une allergie. Et la base du traitement, c'est pas les antifongiques, c'est les corticoïdes.
Because en France, c'est pas la même chose en France, non? Ben, je suis pas très fort en parasitologie, mais bon, j'envoie mes malades normalement dans les CHU qui les prennent en charge, mais souvent, enfin, la plupart du temps, ils utilisent les deux en même temps.
So he says it's not the same in France. You use both treatments, steroids plus itraconazole at the same time.
Yeah, there are papers supporting that nowadays.
Yeah, thank you for a very nice talk. I think yes, we have probably a different approach regarding the ABPA, because in France we have a national protocol, and it's true that we use corticosteroid and sporanox. So I think that there is no recommendation so strong to recommend only oral corticosteroid or the association.
No, I think there is a recommendation for use of steroids as a first line therapy. I think the lot of work from the ABPA came from India. One of the largest contribution from PG Chandigarh. So it is logical. It is evidence based to use steroids in the first time diagnosed ABPA patient. But there are patients, and there are the papers were coming out about the combination of this. And if it comes to the evidence, then it can revolutionize the treatment of ABPA.
I think that probably one key of the response is that sometimes in practice it is very difficult to have a very specific diagnosis.
Yeah, that is where I made the underline.
And that's why in some cases...
So that is where the key is. That is where the key is. You should be very, very confident about the diagnosis of ABPA before starting steroids. So, because if it is going to be an invasive form, then it is a double-edged weapon. So we have to be very sure on ABPA. ABPA we see day in and day out in OPD practice, day in and day out. But we have to be very careful, there is no invasive form. There is no invasive form. And we should not diagnose ABPA in immunosuppressed individuals. So that's a key. That's a key.
So, I'm a pediatric pulmonologist, so thank you for your beautiful talk. It was very interesting. So our French position in CF, I'm not talking about asthma, so as a pediatrician I deal more with ABPA in CF patients, children and adults. And you're totally right, like the first line treatment in ABPA for CF will be steroids. But still, the official European and North American position, according to ABPA in CF patients, would be the association between steroids and itraconazole, and in some cases, but I do agree with what you said, voriconazole. But the biggest, we sometimes have to go on with steroids for 6 months, 9 months, because until now we don't know. We are convinced it's an immunological problem more than an infectious disease. We still know if steroids alone could help as much as the association of steroids and itraconazole. So I think in France, in Europe, in North America, according to CF, since we don't know much today about the role of Aspergillus, since the carriage in CF patients, the bronchial carriage is up to 25 to 30% of our patients, and ABPA in CF is less than 2%. So we still go on with the association of itraconazole and steroids.
Yeah. I fully agree with you, sir.
Okay, anyways, thanks a lot.
And we see less number of, we see less number of CF in our country, and there is regional difference even in our country. We see in our country, North India has a lot of CF than in South India, and it's a sporadic. We see sporadically only CF here, and especially in CF, we used to be very careful before starting treating ABPA with steroids before we rule out invasive form. So recently I had a child with CF, presented with bronchiectasis, diagnosed with CF, proven by genetic test, but there were nodules in the lung, so I didn't use steroids because the bronchoscopy cultures during by electron was elevated. There is a high suspicion of invasive IPA. ABPA can coexist with the IPA, invasive pulmonary aspergillosis. There we use voriconazole. So our decision on to use which molecule depends on the clinical situation and our diagnosis. So that will change our choosing of drugs. So ultimately it boils down to the guidelines are only to guide us. It is not that you should use the only the guideline ABPA first line of treatment. It's not so. So it's up to us to decide which molecule to be used in a given situation. So that's why patients are coming to us.
Quels sont le pourcentage de traitement par le corticoïde dans ses études à lui, parce que c'est quand même une maladie infectieuse. On sait bien quand il y a une pneumonie et vous utilisez la corticothérapie, vous cachez pas mal de signes cliniques. Est-ce qu'il n'y a pas de catastrophe après leurs attitudes?
So he asked the question, in your experience, in your studies, what is the percentage of success in patients treated only with steroids for IBPA? And he takes the example of, let's say, pneumonia or severe pneumonia. You also give sometimes corticosteroids, but you mask some other signs. So
it is between 70 to 90%, sir. 70 to 90%.
70 à 90%.
Provided patient is taking correctly the dose and follow. The problem with us is, see, unlike the RNTCP program, National Tuberculosis Control Program, if the patient is not coming to collect the next boxes, the healthcare worker will reach the hospital, will reach the patient's home, but it is not so in ABPA. Because the problem for us in continuing and completing the course of the treatment of steroids in ABPA to see success is, once you start steroids in ABPA, after 4 to 6 weeks, patient will improve. So good number of patients will stop thinking that he is cured, but they will come with relapse later on. So that's a problem.
Donc il dit, ces taux de succès très importants, c'est seulement si les patients prennent les médicaments de façon surveillée. Et il dit, dans la tuberculose, si les gens ne viennent pas prendre leur prochaine boîte de traitement, etc., on va les rechercher, on va faire, et pas dans la BPA. Donc il dit, il faut absolument que les traitements soient surveillés, et pas que les patients arrêtent au bout de 4-5 semaines, alors qu'ils croient qu'ils sont guéris. Il faut qu'ils continuent pour toute la durée du traitement. Et c'est comme ça qu'il explique ces beaux taux de succès.
Merci beaucoup.